Welcome to this week's Wellbeing at Home event. This is the last one of this year, so we're taking a Christmas break. And as I say every week, it's very heartwarming to see your familiar names and faces. And today I've made you show me your faces, so today it's your faces too. Thanks for taking the time, coming along. You know, we have some amazing experts and they give us their expertise and their time, so we can all benefit really and empower ourselves, as I say every week, make ourselves happier and healthier, and take control of our own health so that we can lead better lifestyles and better lives. So today, to finish off 2021, I am delighted to have with us my dear friend Stephanie Goodwin, Dr. Stephanie Goodwin, who is an awesome doctor. And I love Stephanie because she's just so down to earth and practical with her advice. And look, she can deal with me, she can deal with anyone. So Stephanie has personally helped me with my own hormonal issues, and I'm actually in a good place now, Steph, thanks to you, so that's great. Yeah, but she guided me through all my own kind of hesitations and worries about everything and anxieties, so she knows her stuff. Now, Steph, you're a private GP, right? But you've also done a lot of training on menopause. And can you just remind us what you had to go through to call yourself a menopause doctor, please?
Yeah. Well, thank you for your very kind introduction, Stella. Very nice. It's nice to see you and everybody. So I'm a GP, and I would say probably 10 years ago-ish, my patients, my friends and me all started to get a bit perimenopausal, and I realized my knowledge was a bit sketchy because I don't think I did any menopause training at medical school. It's a long time ago, things have moved on. And so I started off doing the introductory menopause training certificate at Guy's Hospital. I did some clinics there and really enjoyed it, so I asked them to give me a job, which they very kindly did. And so now I have their advanced certificate, which means I'm a specialist, and now I train other people. So I often have somebody, or usually have somebody, sitting in with me in my clinic at Guy's. So, and every time I do a clinic, I learn something new, whether it's a medical fact or just something about the experiences of women at this time of life. So the more I do it, the more I learn about what it's like for different people to be a woman in their 40s, 50s, and decades after that.
Yeah, amazing. And I hope you're training lots of GPs now, because, you know, GPs, I don't want to pick on GPs too much, but I know, but I will, because I know many people, many of my friends and family go to their GPs and they kind of hit a brick wall at that very early stage. So I believe more GPs are being trained in this area, correct?
Yeah, definitely. There's loads of resources available for GPs. So one hopes that within a practice, there'll be at least one person who's got a special interest in the menopause. I always say to patients, you know, it's not rocket science, this. It's actually, sometimes it's complicated, and then we see people in hospital, but there is plenty of access to information, both for GPs and for women. So if you see your GP and you feel you're not getting anywhere, then there are plenty of resources, and perhaps we can touch on that a bit later, Stella, about being prepared when you go for your appointment, so that you are clear about where you are and what you might want. And then it just saves some of the negotiations.
Yeah, wonderful. It comes back to that point about being empowered about your own health and knowing, rather than, you know, going there helpless and with a victim kind of mentality. So yeah, absolutely. So I think what we will do to start it off, because hormones it's a huge subject, and we have different age ranges present. And so I think a good way to start this is to talk about the decades from 40s upwards, about kind of the symptoms, the main symptoms we would get from a hormonal imbalance, because a lot of the time people don't recognize that they've got a hormonal imbalance. I know in my 40s, I normalized things. I didn't realize that I did have an imbalance, because I just didn't know. So I think it'd be good to look at that so that we know what to do about it, and then move on 40s, 50s, 60s and beyond. That would be great.
Okay. I mean, I think 40s are the 40s are a challenging time, because women and doctors don't necessarily have the menopause on the horizon. And most women will start to get symptoms of the menopause in their 40s. And often the beginning, when you start to feel perimenopausal, so before the time when your periods stop, which can be anything from 6 months to 6 years, it often starts with mood changes, anxiety, lack of confidence, anger, tearfulness. It can be a real exaggeration of PMT. So PMT and perimenopause are a bit of a continuum, I think. So often it's quite subtle, and quite often it's other people around you who notice those changes more than one might do oneself, because, you know, we think we're okay until someone tells us that we're a nightmare to live with. So often in your 40s, the symptoms are of mood disturbance and this kind of anxiety and lack of confidence. And so lots of women that I meet go and have a chat with their GP about it and are offered antidepressants. And the guidelines, the nice guidelines for managing women around the menopause, are quite clear that if you have a patient of menopausal age who's experiencing symptoms of anxiety or depression, the treatment is HRT, not antidepressants. So many women are given these prescriptions, they never take them. And they're insulted because they know they're not depressed and they're angry. And so there's often a gap then between that experience and any further consultations. So that can be one of the earlier signs. Then later on, it's menstrual irregularities, heavy bleeding, very erratic periods. Then once you get late 40s, 50s, these are averages, then you might start to get hot flushes and sweats. Brain fog is a really common symptom that women worry about a lot because they think they've got dementia. They're doing presentations and they forget the topic. So later on, the symptoms can become very intense and sometimes more physical: vaginal dryness, painful intercourse, low libido. And then your periods generally stop in your early 50s. That means you've hit the menopause if you've not had a period for a whole year. Once you get into your 60s, 60% of women in their 60s will still be having menopausal symptoms. So that's a lot.
60%, you said?
60.
Wow.
Yeah. So what happened?
Symptoms?
Hot flushes and hot sweats, very commonly still. I met a woman of 65 when I was at Greyshot a few years ago, actually. She still went to bed lying on a towel every night because she was dripping in sweat, and nobody had ever offered her any advice or treatment. It was terrible. She'd been like that for 15 years, you know. So many, many women in their 60s are still having symptoms. So, and even we've got patients that guys who I see, we've got women in their 70s and I've got women in their 80s who are still symptomatic.
Wow.
So what I don't want is for people listening to think, oh my God, it's a life sentence. Because obviously it sounds grim, doesn't it? All those symptoms, it sounds horrid. But provided that you know what to be on the lookout for and you know where to go to get help, then you don't have to feel bad. Many women won't feel bad, but a lot of women do, because I meet, obviously, people who are coming to see me are having problems, but a lot of women are having terrible problems. So the symptoms can subtly change over time, but I think it's important to remember that you can still get symptoms much later on in life. And therefore, if for those women who do take HRT, don't be sort of tricked by someone into saying you must stop HRT after 5 years, because if you start it when you're 50 and you stop when you're 55, there's a very strong chance that you'll still have symptoms. So I think that's one of the questions I always get asked is, if you're going to take HRT, how long can you take it for? There is no definitive answer. And of course, as you get older, then you're more at risk of other things: breast cancer, heart disease, hypertension. So some symptoms mimic other things. So it's always about checking in. Always check in with a doctor regularly throughout your decades would be my advice.
Sure. Can I ask, I mean, we are going to cover HRT because it is a subject that always comes up. We did cover it last time. I think it's so important because there is still this view that it causes breast cancer. And I know we talked about it last time, but I really would like to get your opinion on that again, please.
I mean, when I talk to women about their worries about HRT, I always start by telling them the positives, because the benefits far outweigh the risks. And I think it's about putting it in perspective. So I always talk about 50% reduction in heart disease, 30% reduction in bowel cancer, protection for your bones against osteoporosis, and reduction in the incidence of dementia, plus you feel better. So you've got immediate and you've got long-term benefits. You've got a lower risk of dying of all causes across the board if you use HRT than if you don't. The breast cancer risk is actually really low. And a lot of menopause specialists like myself, we use what we call body identical hormones, which are widely available for any GP to prescribe. They're structurally the same as the hormones we use in our that we make in our own body. And the evidence really is that using those, when you use those hormones, the breast cancer risk is negligible. It's very, very low. So when we use hormone treatment, we're just putting back a natural bit of what was there before. But the numbers are, after 7 years, it's a 0.1% per year increase in the risk of breast cancer. Okay, so it's very low. HRT won't give you breast cancer if you're going to get it, if I'm going to get it, Stella, because I take HRT. It's in my genes. Giving somebody a hormone that is naturally produced in their body is not going to change your genetic makeup. It might bring it forward if you were going to get breast cancer, but your risk of dying of breast cancer if you're on HRT is no greater for women who take HRT than women that don't.
So why the bad publicity, that study that came out? And it's still, like if you open a packet of HRT, or for example the Estrogen that I told you I use, and there's huge signs,
I know,
huge labels saying, oh, this makeup, where does that come from and why is that the case?
I think it may increase the risk of breast cancer. Okay. But when you look at the data again, what happened was, in the studies that they did years ago, they gave HRT to women who were in poor health. They were in their 60s plus. They were overweight, they smoked, they drank alcohol. And so their risk of developing breast cancer was already higher. And when you look at the data, the newer hormones that we prescribe now, they weren't available then. So now looking at the newer body identical hormones, there's more data coming through all the time that the risk with them is very low. The other thing to stress is that actually your risk of breast cancer is much higher if you drink more than 14 units of alcohol a week. Now, 14 units of alcohol, it's quite easy to get through that. It's only 2 small glasses of wine a day if you measure it out. There's 9 units of alcohol in a bottle of wine. So if you drink more than 2 units of alcohol a day, your risk of breast cancer is higher than if you take HRT.
Isn't that interesting? But nobody says that. Nobody tells you that.
They don't tell you that.
There's no big publicity campaign around that.
About alcohol. No, I mean, they're intermittently, but I think...
But that's a really interesting fact that you've just stated.
That's right. Because certainly many women I meet drink more than 14 units of alcohol a week. A lot more. The women seem to drink more than the men, actually.
Yeah.
And, you know, so that if you're overweight or if you're obese, you're about 5 times more likely to get breast cancer than you are if you take HRT.
Let me ask you about if you have breast cancer in the family, if your sisters have breast cancer, your mother or something like that, or your grandmother, would you advise people to stay away from HRT at that point? No.
What we do is there's an algorithm that we use for calculating your breast cancer risk. So if you've had several members of your immediate family who've developed breast cancer pre-menopause, then your risk might be increased. So what we do with patients is we take a careful family history. If your mother developed breast cancer in her 70s, you're at no greater risk. So the majority of women who get breast cancer do not have a family history, 85%. And it's the same. The majority of women who have a family history don't get breast cancer. So, you know, it's very carefully calculated. But again, many women I meet are told, well, you know, if your mum or your sisters had breast cancer, you can't have HRT. That's not true. You might have more careful screening, but there's very few people who we would say you can't take it. They would normally have had genetic testing.
Okay, what if you have had breast cancer?
Well, I mean, if you've had breast cancer, it depends, Stella, because some women will have had hormone receptor positive breast cancer and some won't. There's different views about this.
Okay, okay, we'll keep off that one for today.
What I would say is that there's information out there. There's a really interesting chap called Avron Blooming who has written a lot about this. He's a breast cancer specialist. And, you know, the evidence seems to say if you've had breast cancer and you don't take HRT, what happens to those women is they die of heart disease because they're hormonally deficient. So in our specialist clinic, we have women who've had breast cancer who we treat with HRT, but we do it. Not many people would do that, but we take a view with our patients. We look at their risk. If you've had breast cancer 35 years ago and you're symptomatic now and you're feeling terrible, then, you know, the risk is extremely low. It's quality of life versus low risk.
Mm-hmm. Yeah, it's interesting. And I remember listening to Avron Blooming's podcast. He did a recording of something, and I was fascinated about how many women do suffer from heart disease and cardiovascular disease through the hormonal imbalance, and how that helps women kind of have, as a big precaution against cardiovascular disease.
I mean, you know, one of the things we spoke about last year when we did our heart disease session was that women don't get heart disease until after the menopause, and that's because estrogen is very protective for the heart. Mm-hmm. So, you know, these are individual decisions. For complex cases like that, you would need to be referred to a menopause specialist, but we take a broader view and we listen to what the patient wants.
Right. I've got some questions in here, so I'm going to just address them as we go along. And thank you for those of you who did email me the questions, because we're going to cover those as well as we go along. So Wilma says, can muscle aches be a symptom?
Yeah, definitely. Yeah, I mean, we've all had those, haven't we?
Yeah.
So muscle joint pains, stiffness are symptoms.
And that's lack of estrogen, right?
It's usually lack of estrogen. Sometimes it's due to other hormonal deficiencies, thyroxine, for example, but it's very common for perimenopause and menopausal women to have muscle pains, and joint pains.
Sandrina gel, is that a body identical estrogen?
Yeah, so Sandrina gel is an estrogen gel. It comes in little sachets, and yes, it is body identical.
Okay, great. Ruth's concern about HRT, she'd had a DVT in the past and tendency to clot.
Okay, so a DVT is a deep vein thrombosis. It's a clot in your leg. If you've had a deep vein thrombosis or a pulmonary embolus, a clot in your lungs, or any clot, you can't take estrogen orally, so you can't swallow it. The reason for that is that it activates clotting mechanisms and it increases the risk of a clot. If you've had a DVT or some other clot, you can have HRT, but it can only be given to you through your skin. So either as a gel, a patch, or there's now a spray. So it's not, it doesn't mean that you cannot have it, you can.
Okay, great. And there's no risk of having it as a gel to your clotting?
There's zero, it's completely neutral in its effect on clotting. There is no greater risk at all with an estrogen used through your skin.
Great. You see, that's interesting, as Ruth's question. It's a really interesting question because she has a view. Obviously, someone's told her that.
Yes.
But without getting into that detail.
Yeah, I know.
Yeah. Kilofem. Is that identical?
Clifem isn't. The estrogen in it is, the progesterone part of it isn't. But it's useful. I mean, we try and use body identical hormones if we can. With oral HRT, in the last 2 months, they've actually brought out now the first combination oral body identical estrogen and progesterone, which is really, it's brilliant actually. It's called Bijuve. And it's for women who have really stopped having periods. You just take it every day. And the benefit of the body identical progesterone when you swallow it is that it helps you sleep and it's good for anxiety.
But I've got to tell everybody, progesterone is it's like being on a happy drug. When I started to take progesterone, it totally changed my life. I mean, I just felt so much more at ease with myself. It was incredible. Until, when you told me I was my progesterone was very low, of course it made sense at that point. But yeah, progesterone is an amazing thing. So
your best friend.
Yeah, it's my best friend. What did you call this? It's
Bijuve. Bijuve.
And this is body identical combined estrogen and progesterone.
Yes, it's available now. It's been, I mean, I remember hearing about it about 5 years ago when I was at the European menopause meeting in Madrid, and we were all really excited about it. And then it's taken until now for it to have actually been produced. The ingredients in it, the estrogen and progesterone in it, have been around for many years. So it's not a new treatment. It's just that they've been able to combine it in one capsule. So, provided you don't have a history of clots or migraine, we avoid oral estrogen in women with migraine. It's a brilliant solution. It's just one a day, you swallow it, happy days, off you go.
And this you give to, you said, post-menopausal women.
Yeah, I mean, it's really designed for women who have not had a period for a year, or who are aged over 54. That's when we would use continuous HRT. So basically, if you're still having periods fairly regularly, it's not going to be right for you. It needs to be for people who've pretty much stopped having periods.
Okay. I did have another question that came in via email about this, about the types of HRT. So is a combined estrogen and progesterone patch better than an estrogen patch and a progesterone pill?
So you can get a combined estrogen and progesterone patch. The estrogen relieves symptoms and gives the heart, brain, bone protection. But estrogen causes the lining of the uterus to thicken, therefore you have to have progesterone as well. So there is a combination patch called Everel, either Everel Conti, which means you don't have a period. It's for women who basically have stopped having periods. And then there's another one called Everel Sequi, which induces a bleed, if you like. Personally, it's not something I prescribe very often because the progesterone part of that patch is not body identical. It can give women PMT-like symptoms. and you do quite often get breakthrough bleeding with it. So, and it's a big, it's a bigger patch. So for me personally, I don't prescribe it very often. But for some women, it's absolutely great. If they just want to put a patch on, change it twice a week and forget, then it's brilliant. The advantage of using the patch and the capsule separately are, if somebody comes to see me and they are having problems sleeping and they're feeling anxious, which are 2 of the top 10, I would say, symptoms of the menopause or perimenopause, then when you swallow the progesterone capsule, which is called Utrogestan, that's the only way you get the benefit of it helping you sleep and reducing anxiety. It doesn't work if you have it as a patch. It doesn't work if you take it as a non-body identical hormone. So for women who are having anxiety and sleep problems, for me, they definitely need the progesterone capsule. You either use that with a separate estrogen patch or gel, but now we've got the benefit of this combined estrogen and body identical progesterone capsule by Juve. So we've increased our armory of treatments.
Okay. I'm going to ask a question actually at this point. If you have a Mirena, and which actually ceases your bleeding,
yes.
How do you know when you're in menopause? If you've gone into menopause, if you don't have any other symptoms?
So Mirena is it's an intrauterine device. It's described as a coil. It shouldn't, because it's not a coil. It's a small plastic T-shaped thing. It has progesterone in it, which makes the lining of the uterus very, very thin. So for many women, they stop having periods, and it's very good. It's a very effective contraceptive. Of course, then you don't know if you've stopped having periods. But if you're becoming perimenopausal, though, you generally will still get symptoms. And so you can still be treated with estrogen. We can do a blood test. We look for a hormone called FSH, which is follicle stimulating hormone. That's produced in the brain. It's sent down to the ovaries. It tells the ovaries to do something. And if the FSH level is high, it generally means that the ovaries are not working very well. So we can do FSH, but we can also just treat based on symptoms. So the fact that you're not bleeding, if you're not bleeding and you've got 0 symptoms, then maybe you're not menopausal. We can do a blood test. But generally, if you're getting any symptoms, you can just use some estrogen, and you don't have to worry about the progesterone, because the Mirena is doing the job of keeping the lining thin.
Okay, thank you. I did have another question that came in about post-menopausal bleeding. So if you're officially in menopause, you've been in menopause for a year, you haven't seen the period, for a year, and then you bleed after that, after 2, 3, 4 years, what should you do?
So the general rule is, if you've not had a period for a year and then you bleed, it needs to be investigated. Right. So generally that means an ultrasound scan, make sure that the lining of the uterus isn't over thickening, make sure that there aren't any polyps, something like that. So if you bleed after a year, then go and seek advice and it will be investigated. Sometimes if women have not had a period for a year and we put them on HRT, you might get some bleeding then. It's not uncommon, because we're kind of waking up all the estrogen receptors. And we would normally, between 3 and 6 months, we would accept that you might get a bit of bleeding. Anything more than that, then we would investigate. And I sometimes, with my patients, I think it's not a bad idea to have a scan done at the outset, just to make sure that there isn't a polyp or something there before you start using more hormone treatment. But that's not widely available on the National Health Service, but you can get pelvic scans done relatively inexpensively. So but unscheduled bleeding needs to be investigated.
Okay, I'm just going to flip away from HRT just for a second. I'm going to come back, because there's something there and it's made me aware of it. What do you think about having frequent checks as women, like medical health checks as women, and what should we be doing and how often should we be doing that? Whether it's on the NHS, what are we entitled to on the NHS, and if not, should we be going privately, having blood tests or whatever?
I think the most important things to check for, the things that go wrong with every decade, are generally very simple to screen for. So, for example, checking your blood pressure. I recommend everybody just buy a blood pressure machine from Amazon. You can get one for 30 quid, because high blood pressure is insidious. It causes all sorts of problems. So in your 40s, check your blood pressure, have your cervical smears done, blood testing. It's not a bad idea to have a cholesterol level done. And GPs do invite women and men, 40s, 50s, you get invited for a health check. Get your urine checked, make sure you
Really? I've never been invited.
Actually, I haven't either. But for some, you should be.
Some GPs invite you. Okay. Yeah.
I think what's happening now with this new vaccination program accelerating, they're now saying that they're going to stop doing this screening.
Outrageous. Anyway, don't stop me off on that.
We won't talk about that, Stella. But things like simple checks, diabetes, look at your family history. Make sure you ask your family members, what have people got? Lots of people say, well, my mum's not very well, but I don't know. She's on 20 tablets, but I don't know why. Find out. Right. Our genetics are really important. That gives you clues. And your 50s again, blood pressure, diabetes, cholesterol, they're the things that people die from. Now in your 50s, I think in your late 50s now, they're bringing forward this stool test to look for bowel cancer. Yeah, if you get sent the kit, do it. Don't just leave it on the shelf for 5 years. Which is
so what are they should be coming to you with a stool test for do it yourself stool test for bowel cancer.
Yeah.
Okay. But what should we be going in and rather than waiting, again, being more proactive rather than waiting for them to come to us with what we should be doing?
So in terms of that, Stella, the number one thing is find out about your family history, because if you're fit and well and you go to your GP and say, can you do some tests on me? I just want to be careful. They're going to say no, because it would be impossible to do that on everybody.
Well, especially nowadays, yeah.
Yeah. But I think having your blood pressure checked, if you've got a family history of diabetes, get your blood glucose level checked, get your cholesterol level checked. So they're very simple things. Generally speaking, if my patients have asked for those things from their GPs, they have been done. So they're the key things: blood pressure, cholesterol, diabetes. In your 50s, again, it's the same things. It's the same. They're the commonest cause of death. Have your mammogram done, have your smear done. When you get into your 60s, see, our risk changes with each decade. Then for women in their 60s and men, think about having a bone density scan. Osteoporosis, broken bones, are a massive cause of a cost to the NHS and a cause of illness and death in older people. But I think, honestly, if you want to be proactive, to some extent, you have to take it upon yourself.
Yeah, exactly, and that's what I would like to just talk a little bit more about here, because I think there are those tests, those packages that you can buy. I don't, that some are more expensive than others. Some are I don't know, a couple of £100, some are £500 or whatever. You can go in and have like the Well Woman checks.
Yeah,
I think Nuffield do those.
Yeah,
and I think they're a great investment, aren't they?
So. I mean, look how much I spent £600 on my car 2 days ago.
Exactly.
So we think, oh, I've got to do that because if my car isn't safe, I'm not safe. Yeah. Maybe if you spend 200 quid on yourself once a year, you don't have to spend a fortune. But somebody you do need to have your blood pressure done by a machine. Yes, you can get finger prick tests done, but the chemists, people like Superdrug, you can go and get your bloods done there. Mm-hmm. And then a doctor will discuss the results with you. You've got to have someone to help interpret the results in the context of who you are and what your personal risk factors are. Yeah. So I think we have to be more responsible for ourselves.
You've heard me talk about this before, and I think some other people who've been here have been talking about this before. As good as our National Health Service is, it's not preventative. It's very reactive. And if we get sick, we go there. But we need to take control. And we've seen over the last couple of years, it's so important to take prevention. So there's another couple of questions. Claudia says, where can she get a stool test from?
Well, the stool test will be sent to you. It's part of an NHS screening programme.
Okay. Well, you're not going to get it right now, Claudia, but you can check with them.
Have a look. Just have a look on the NHS bowel cancer screening website is what I would suggest. If you've missed it for some reason, you can request one.
And do you only get that at a certain age, though?
It's usually 60, but I think they might be bringing it forward to 57, but I would suggest looking on the website. If you've got a strong family history of bowel cancer, if somebody's got it early on in life, tell your GP about it, because if they don't know, they can't do anything. But if you've got an awful family history, you can be referred to have a colonoscopy done when you're younger.
Right.
So, but it's only, people only can do stuff if they know your history. So I think it's terribly important. Right.
And you can get them privately as well if you need to. Louise asked, could you share any insights on treatment for low bone density? Yes, and this is a question that came up for somebody sent me a question about what should women do in their 70s. And so I'm thinking about low density osteoporosis, which is the most common thing, right, in that decade, or even before.
I mean, low bone density. Your bone density drops massively within the first year or two of the menopause. That's when maximum bone loss occurs.
Really? So if you have a menopause at 52, then your bone density will drop immediately within the next year. Wow.
It drops really quickly because estrogen is so important for the bones. So one of the main things that I think is very important is doing weight-bearing exercise. And, you don't have to be in the gym lifting massive weights. Anything, resistance exercise, those elastic bands you can get. I've bought some of these Velcro little weights that you put on your arms. Quite hilarious, but, you can walk around your flat and throw yourself around with those on. Simple things. It doesn't, we lose muscle mass very quickly. And that's really important for supporting bone strength. Eating a healthy diet is really important. So, fish with bones in, pulses, calcium-rich foods, really important. There's loads of information about that on the...
How about calcium supplements?
Well, calcium supplements, you shouldn't take a calcium supplement unless you have got osteoporosis or unless your diet is terrible. The reason for that is you have to be careful with calcium, because if you've got too much on board, it gets deposited in places where it shouldn't be, like in your coronary arteries. So the guidelines are you shouldn't take calcium unless you have osteoporosis. That's the bottom line, really. So it's more important to exercise. That's a better source. If you have got a family history of osteoporosis, if you haven't had a period for a number of years and you're not using any hormonal treatment, go and get a bone density scan done. You can get a bone density scan done for about £100. It's not that expensive, and it will show you what your bones look like. If you have osteoporosis, the best treatment for osteoporosis is HRT. Okay, it really improves bone density. It's not there's other treatments, bisphosphonates, which are pretty heavy duty drugs with lots of side effects. So the number one treatment for women of around the age of the menopause, if they've got osteoporosis, is HRT. So, but if in doubt, get a bone density scan. Just have a look online. There's plenty of places that do them. Better to have, you can get these screening bone density scans where they look at your wrist and your heel. If you're going to do it, go and have a proper DEXA scan where they look at your hip and your spine. You will pay at least £100. If you can get a density scan for £50, it's not going to be that helpful, would be my advice.
What is it called?
It's called a DEXA scan. I can send you the name of the clinic, Stella, that we use, where I know it's £100.
Perfect. Okay, perfect. So Louise has an actual question about this. She says, insights on treatment for low density, such as alendronic acid.
So alendronic acid is a bisphosphonate. So these are they're potent drugs which do improve bone density, but they have side effects. So, you know, I wouldn't want to take a bisphosphonate, to be honest.
Okay.
They can cause problems with the density of the bone in your jaw. They can cause atypical fractures in your leg. I mean, they're pretty potent. So, but for some people, that is the choice. And depending on their age, that might be considered to be the best treatment for them.
You would recommend HRT over and above that if it's okay for that individual. Okay.
It's because it's also got so many other benefits, which bisphosphonates have no other benefits, only risks.
Okay. Gosh, we've covered so much already. So Sheena asks, is there an alternative to alendronic acid? Yes, HRT, Sheena.
But there are other alternatives as well, Sheena. So there's injections that you can have every 6 months, which work really well. And there's also an annual infusion, a drip that you can have. But with these, they work really well. It's much more convenient than taking alendronic acid. They're very expensive. So some GPs or practices, it won't be covered, but some health insurance companies might do, or you might take a view. It might cost you £350 or £400 a year, but it's only once a year or twice a year.
Right. Interesting. So there was a question that came in, which is an interesting one, and it's something that entered my mind as we were talking. Some women just don't have symptoms, right? Yeah. Some women actually just sail through it all and it's fine. Yeah. And I think maybe in the good old days, let's say, but maybe we had simpler lives, and our lives were simpler on that basis. Obviously, our medical advancement wasn't as great, so we suffered in other ways, but certainly with regards to hormones and hormonal issues, there's a lot of women. I mean, my grandmother lived until she was almost 100. She didn't have any of these issues.
Yeah, sure.
So, there are some people who just kind of sail through it, right?
Yeah.
Why do you think we have more issues now than we used to, or did people have them? We don't.
I think we always did. But first of all, we're living longer, remember.
Yes, that's true.
So, if you live longer, you're more likely to have bowel cancer, cardiovascular disease, dementia, and osteoporosis. If you're dead, if you were dead at 60, you'd miss all of that. So we're living much longer, and these diseases of old age. Let's be honest. Who wants to be 85 with dementia and osteoporosis? I don't. I want to be in the best possible health I can be. But sure, there are women who have no symptom, who are fine. That's great. That's great. My advice is HRT. I'm not saying everybody should have it. I think everybody should know the benefits and then make their own decision. But if it's something that you feel is not right for you, that's absolutely fine. But make sure that you assess the risks of the things that you're not being protected for. So check your bones, check your blood pressure, check your cardiovascular system, because you won't get the benefits of hormonal treatment to give you protection for that. So it's just knowing what are you more at risk from, and then making sure that you've got things in place to reduce your risk of those conditions.
Right. Yeah, I think it's also a mental shift, because certainly, me, I'm very much into natural health, and I like natural health approaches. And when it came to this, I had a block about it, because I was like, this isn't natural. And until we discussed it, and I kind of got over my block, and I realized how much it actually helped me. And now I don't even think about that, and I can combine living in a healthy way with a healthy lifestyle and supplementing it with natural health approaches. But I think it's just this kind of one size doesn't fit all, and
also, Stella, I always say to women, and I know this because I'm a post-menopausal woman myself. So it's not just about somebody giving you a prescription for HRT and off you go. It's not just that. There's a much bigger picture. It's a really complicated time of life. There's so much change. The demands on us are so high. So, you know, it's you have to do everything. You have to exercise. You have to eat healthily. You have to take time out. You have to check in with yourself. Where are you in your life? Because a lot of women, when they hit the menopause, stuff's going wrong, you know. And I would say this isn't gonna. I can't sort out your problems. You'll feel better, but you're still going to have to deal with the stuff that's going on. So I think it's a really important time of life for just taking stock of where you're at and making shifts and changes. So the prescription is just one part of the equation. But it's a much bigger picture than that.
Right. And there's another couple of questions that come in, which we'll take now. But then I want to touch on, you know, that what we talked about having practical advice around certain parts of your life, like in your 60s, where you may have elderly parents, and just things that you've come across with patients that you think are just practical tips. So can you take HRT, some kind of HRT for the first time well after menopause, such as 60 upwards?
So the general view is, ideally you want to, if you're going to take it, you want to do it within 6 years of your last period. But really within 10 years is pushing it a little bit, because you won't get all the long-term health benefits if you leave it too long. And also, if you start hormonal treatment in women who are a long way post-menopause, you might increase their risk of cardiovascular disease. I think that's highly unlikely if you're using body identical hormones and you're using your estrogen through your skin. But for me, if I've met women, and I have done, who've been suffering for years, and actually nobody's done anything to help them, I'll give them I'll just start them on a very low dose, and it transforms their lives. They can sleep better, you know, all the symptoms go away. So you can do, but I think if it's a long time since your last period and you're having symptoms, I would suggest seeing a specialist, because your GP won't give it to you.
Right. Okay. I think some people are looking at it at that point as a preventative issue. So say you don't have issues, but you're in your 60s and you think, well, it brings me so much benefit. Can I?
Yeah. If you leave it for too long, you can't take it for long enough to get those cardiovascular bone benefits.
Okay.
So it needs to be ideally within 6 years of your last period.
Okay. Have you any tips for boosting vitamin D, especially in winter?
Take a supplement.
Yes. 400 IUD minimum a day.
Minimum, yeah.
Just do it. Yeah, just do it. No discussion on that one.
Yeah.
Now this is good. These good questions. If I ask my GP to move me from Clyofem to body identical, will they easily do this, or do I need a good reason? And if they don't get a satisfactory response, what can they do?
Well, I think what you want to do is go in with a solution. Just say, I've heard that this might be better. Could I switch to a patch and this capsule? Obviously, I don't know this lady's situation, so I couldn't really suggest what she needs. But I think if you say, I'd like to switch to estrogen through the skin, I hear there's less clot risk associated with it, and maybe if you don't sleep very well, you might get the benefit of the body identical progesterone. And go in knowing the names of things, patches and the gel and the capsule, then I don't think they'll have a problem with it.
So you have to do your research basically before you go in. I think sometimes I've seen that with my mother. My mother does all her research and goes in and tells the GP what he must give her.
Which sometimes works.
It works. I think they just want to get her out.
Well, that's right. They want to get the next person in.
Yeah. But the strategy can work.
Yeah.
So let's talk about like this time of life where we as women do end up with more responsibilities with I mean, many of us who've had children they've moved away, but then we end up with another responsibility, which is our elderly parents. A lot of us have that, and as women we kind of bear more responsibility for that.
Yeah. I mean, it's a challenge. I've got elderly parents. I mean, I wouldn't call them elderly for a long time, but my dad is now nearly 89, and he accepts he's elderly. Well, actually, no, he doesn't. That's rubbish. Still chopping trees down. But anyway, but it's hard. I mean, I have 2 sisters. We've all got really busy jobs, and sometimes I have to drop everything and rush because he's taken into hospital, which happened a couple of weeks ago. But I think it's really important to be upfront with your parents about how you're going to manage situations, making sure that you've got lasting power of attorney for finance and health, so that if there's a problem, you can step in. Lots of families don't have that. It's very important. You can do it online, but it's really important, because otherwise you can't make decisions for people if they don't have mental capacity. So I would definitely look at lasting power of attorney. Has a will been done? I mean, we don't want to discuss this stuff, but you have to be practical about it. Where are things kept? Are things in order? Otherwise, you just have a mess to deal with, which is hard enough. And a patient of mine made a really helpful suggestion to me last week, which I hadn't thought about, and I shared it with a GP friend of mine whose mum's not very well. And she said to me, make sure you're on the name. If you've only got one parent left, get your name so that you're a joint account holder on their bank account, so that if there are problems, you don't use it unless you need to, but you've got access to their money. Otherwise, it's a real headache, even if you've got lasting power of attorney. So I suggested that to my pal, and she's spoken to her mum, and they've done it. And it means that if she's suddenly really unwell but has to pay for stuff for her, she can do it. So just a really simple thing like that.
Yeah, just really practical tips. Thank you. I think these are things that we don't think about, because but these, because the other thing I wanted to ask you is, what can we do as women when we do, a lot of us do have these all-consuming jobs or families or other things, and then we have the additional responsibility of maybe elderly parents, plus we have hormone imbalances and everything. It's like you say, it's like a perfect storm, right?
Yeah, it is.
So get our hormones sorted and get everything, all the practicalities sorted as well.
I mean, make sure you feel well. I mean, I've been so busy in this whole lockdown period. I've been working. I haven't been in lockdown. I've been in my office pretty much all the time. But I've met so many women who are utterly at the end of their tether, who have just put up with their symptoms, thinking it's lockdown, it's stress, and blah, blah. It's not. It's much bigger than that. So get help and advice, and talk to other women about it. So share information, like I shared with my friend about the bank account. That's really helped her. So share information. Make sure that you get some time out for yourself, even if it's only 15 minutes. I mean, hopefully it would be more than that. But we've got to look after ourselves, because for many women, we're holding the whole thing together. If we fall, the whole thing collapses. So have a support network somehow. I always say, have a hobby. I mean, you and I, Stella, we're hobby mad, aren't we?
Yeah.
We've got lots of hobbies, but have something that takes you away from everything else, even if it's only half an hour of us playing our drums, something that brings you joy, that maybe you don't do with anybody else that and it's just your space. So I think it's a huge topic, but I think when you chat to other women particularly about it, that's where you get support and information from people who are a bit older, who have been through that with their parents, finding how do you find a nursing home, all that sort of stuff. It's such a headache, but there are people who've been through it before and who can help you. So I think it's about sharing how you're feeling and asking for help when you need it.
Wonderful. If anybody has any last questions, put them up on chat. Otherwise, I think we're going to close it now. I think, Steph, thank you so much for, oh look, how can we book this? I knew this would come up. Okay, unfortunately, Dee, Steph is so busy with patients right now that she's not taking anyone on until March next year. Afraid so. But you can put yourself on her list, right? For then,
book an appointment. Yeah, you can book an appointment. Yeah.
Okay. Any number one maintenance / preventative tip, your top tip to avoid the worst?
Well, personally, I think that the top tip is to be armed with information. Be armed with information, make the right choice for you. I think personally is to take hormone replacement therapy, but that's my area of expertise. I know all the facts, but I think make sure that you know everything you need to. Don't be fobbed off, and then make the right decision for you at this time of life.
And there's a really good website which gives you some great information, which is Menopause Matters, right?
Yeah.
I'm just putting it up here. Menopause Matters. It's a really good website. You can find lots of resources and information there. And the good thing is, I think with menopause now, it's become recognized as a medical condition. Lots of industries, I'm seeing it in the business world. It's been addressed by major corporations. We've arrived at that point where it's recognized that women who are hugely talented, who've got all these years of experience, and they're going through these few years of difficulty, shouldn't be just kind of cast aside, and they should be supported through that.
Do we, Stella? We don't want to lose these women. We have so much to offer. We need to hang on to these great women.
Yeah, we need to hang on, and also for women who are going through that period of time, not to feel like you've lost it or there's something seriously wrong with you. You're going through menopause, and you can come out the other end with the right support. So I think that's really important. I mean, I've got to say, there are times where I forget words and I'm in the middle of a sentence and I'm thinking, what was I talking about? But I know that's normal. So it doesn't completely freak me out, whereas before it would have done. Anyway, thank you so much for being with us and giving us your time. It's so informative, and I love the way you explain everything, Steph, just so in a practical way, in a down-to-earth way. So it's great. And get back to your drumming. Steph and I have taken up drumming. So Steph has got her bongo drums, and I've got my African djembe drum, and so we're into drumming right now. But take up a hobby, as Steph says. It's a great thing to do. Just do whatever it is that brings you some joy and happiness. So at this point, I want to wish everyone a wonderful festive season. Enjoy your time with your loved ones. Take time out for yourself. Don't stress yourselves out too much, and look after your health and happiness. And I will be back with you next year. We'll be in touch. But in the meantime, have a lovely Christmas and a very happy New Year. Take care. Bye, everyone.